Hi, and welcome to Healthy Males Real Talk Diabetes and Sex webinar. My name's Simon von Solden, and I'm the CEO at Healthy Male. As you probably know, this week's Men's Health Week, and today we're talking about diabetes and sexual health, and the effect that diabetes may have on mental health and relationships. We're fortunate to be joined tonight by endocrinologist and adjunct clinical associate professor in the Department of Obstetrics and Gynecology at Monash University, Associate Professor Carolyn Allan, sexual health physician, Dr. Michael Lowy, and primary healthcare nurse and men's health researcher, Dell Lovett. Thanks and welcome, Carolyn, Michael, and Dell.
Thank you, Simon.
Now, just a little bit of housekeeping for all of you people watching out there. If you're watching this from Zoom, you won't be able to use the chat function, but you can ask questions by clicking on the Q&A button in the bottom menu bar. If you're watching this from Facebook or YouTube, leave your question as a comment. We'll answer as many questions as possible during tonight's session because that's why we're here. So let's get started, and we'll start nice and easy for you all. So Carolyn, what is diabetes and are there different types?
There are. So diabetes, Simon, is when you have too much blood glucose or too much sugar in the system and not enough insulin to get that glucose into the cells, because ultimately glucose is what fuels our body and what we use. So the two main types of diabetes are type 1 diabetes, or what was known as juvenile onset or insulin-dependent diabetes. And typically, in the past, that's affected younger populations, but we now see it also in older populations. That's about 15% of diabetes. Most diabetes is in fact type 2 diabetes. And when you think about diabetes, that's really what we're referring to. That's when you in fact don't have enough insulin to overcome the amount of glucose in the system. And that's really the lifestyle related disease. There are other rarer types related sometimes to medications, but by and large, when people think about diabetes, they think about either type 1 or type 2.
Right. And so are either of these more common for men?
Well, neither. You're going to see more type 2 diabetes because typically that's what we see more of in the community, and men are more overrepresented in type 2 diabetes, but they are equally as likely to get type 1 diabetes as are women.
Right. And so is there a time in life that type 1 diabetes or type 2 diabetes develops?
Yeah, usually we see type 1 diabetes. We think about that in children, and we know that these children, are going to be dependent on insulin for the rest of their lives. So that's typically where we see it, but you can have a little bit of overlap. And historically, we think about adult onset or type 2 diabetes, but with increasing rates of obesity in the population, we're now seeing type 2 diabetes present even in younger and sometimes in extreme circumstances, even in teenagers. But for our adult male population, predominantly if somebody's got diabetes, 85% of that population are going to have type 2 diabetes.
Right, okay. And so are there certain sort of signs and symptoms that you'd look out for, or like a fellow would go, oh, I think I've got a problem here? Or
So sadly, we know from research that's been done in Australia that half of the adult population who've got diabetes don't actually realise they've got diabetes because the symptoms can be subtle and in fact none at all. And these are the people that we worry about because there can be damage being done in the background before the diagnosis is made. But if you're going to present, then sometimes you'll actually present with what we're here talking about tonight, and that is erectile dysfunction. And if a man comes along and says, I've got erectile dysfunction, then one of the first things their doctor's got to think about is whether they've got diabetes. Other symptoms when your blood glucose levels are higher can be more likely to have infections and increased thirst or passing more urine.
Right. So, Michael, as a GP, I mean, when would you see someone?
Well, I tend to see them a little bit later on because I work in sexual health. I see them when there may be some secondary effects of the diabetes impacting on their sexual function. And I mean, I also see a cohort of older men in any case who don't have diabetes, but so I see older men who may or may not have diabetes, but the diabetes men are a bit more at risk of changes in their sexual function, like drop in their libido. They may have difficulty achieving or holding an erection. And in worst extreme, they may have trouble with their orgasm and experience something called retrograde ejaculation.
Right. Now, Dell, you would have seen a number of guys with diabetes. So I suppose the question is, what does a day in a life look like for someone when they're living with diabetes?
So again, Carolyn explained the difference between type 1 and type 2 diabetes, that it's usually a different age bracket that we're talking about. So people with type 1 and type 2 diabetes can actually live a long, healthy life. And it's just about, I suppose, that managing those challenges, and there certainly are with both types 1 and 2. And that's where having a healthcare team to support you through that is really a great investment for your future. And where it can impact mainly are things, when you think about it, when a person drives a car, where their work environment, and for a younger person with type 1 diabetes, their school environment, when they travel overseas, when they're considering possibly a female more so, but with pregnancy, and probably, what's that other one? With health insurance. It can sometimes be a problem to get really good health insurance. But there's a lot of information available on the Diabetes Australia website that, clearly goes through these issues.
So you talk about a healthcare team, like I suppose to Joe Average, what's a healthcare team? What do I have to do? Go and get myself a footy team of people ready to help me, or what?
Well, I think this is where the investment is really important, and this is where the general practitioner is really the care coordinator. So having a good relationship with a GP over a period of time sets you up then to have the opportunity to access a whole series of other health professionals that can provide different types of care at different times, because diabetes is a progressive illness, and what you might not need as a younger person, you may require later. So the GP's there, and another very good thing to do, because it's often there are several different people involved in diabetes management. It's really good to have a My Health record, because that means that even when you're travelling away, that you've got a health record there that health professionals can look at with your permission and gain a greater insight into your diabetes management. So the GP's there, certainly the endo or the endocrinologist, and that's the specialist doctor who is really about looking at the hormones and managing those in a person's body. So they're a very important person to help prevent complications occurring. Then there's probably there's the nurse that works in a medical practice. They're great for day-to-day questions that you may have. So you can always chat to a nurse. People find it sometimes that the doctor's busy, and so the nurse may have a little bit more time with the patient. So, feel free to ask the nurse those everyday questions. Then I suppose it goes on to the cardiologist, who obviously for any heart issues, the nephrologist that looks at any kidney issues. And sometimes as diabetes, it's a 24/7 illness. So psychologists may also be part of the team, and it just varies. Also, self-help groups are very good for people with type 1 and type 2 diabetes, so they can talk with other people about how they manage and things that they do. So the team is quite comprehensive, and it can make a very big difference if people involve those team members.
Right, that's really good. Thanks, Dell. And so, Carolyn, you've told us sort of the different types of diabetes. I suppose one of the questions I'm interested in is, how do I not get diabetes? How do I not get type 1 diabetes or type 2 diabetes?
Well, so type 1 diabetes is more related to genetic factors. And we think that if you've got a predisposition and there are sometimes other members of the family that have got diabetes or other conditions that we call autoimmune conditions, and that is where the body acts against itself, if you like. And we think then that particularly for type 1 diabetes, because it's more common to develop it in spring and autumn, that a viral infection might be the trigger factor, if you like. So there's not a lot you can do to absolutely prevent it. Having said that, there is some world-leading Australian research going on here in Melbourne looking at interventions, but that's very specific, and there's really very little that you can do to prevent getting type 1 diabetes. Type 2 diabetes, on the other hand, you often have a much more control, if you like. There are still some genetic factors involved, but certainly we think about things more like your weight, your diet, and your lifestyle. And we know even for people that are diagnosed with early type 2 diabetes, if they're able to address those factors, they may well actually be able to reverse their diabetes.
Right. And so if I've diagnosed with diabetes and I start to have sexual health problems, Michael, how do I end up talking to you? How do I get to your doorstep?
Okay. Well, a lot of GPs know about me and refer their patients to me, and some GPs handle the situation themselves. But I might see an older guy who presents to me with sexual problems, and I might he may not have told his GP about it. So by the time they get to me, they usually know what they come for. But I think it's really important, I think, when a GP is looking after a person with diabetes, especially the older man, that the GP does sort of include in the questioning and the history taking, are there any sexual problems that you'd like to discuss with me? That can be a tricky question between the GP and the patient. The GP might find it a little difficult, or the patient might be a little embarrassed. But it is an important question because we know that there is a high incidence in men with older men with type 2 diabetes of sexual problems. We also know that as men age, in any case, they have a high incidence of sexual problems. So it would be nice if the GP included functioning on sexual function as part of the general questions that they ask a patient. But by the time they see me, the questions are pretty much, it's all on the table, and they know, like it's out there. There's no it's all, the patient wants help.
Yep. And so explain to us why if you've got diabetes, you might have problems getting or maintaining an erection. Like, what's the connection there?
Yeah, well, getting an erection is very much a vascular event. It's about blood flow, but also it's a neurological event. And people with diabetes tend to have blood flow disturbances, and we actually call it endothelial dysfunction, and the very small blood vessels become affected. And of course, that's why it's so important to have really good control of your diabetes to minimize that. And also there's some autonomic nerve disruption. Some of the nerves that are involved with getting and holding erection can be affected. So unfortunately, diabetes does sort of, have vascular and neurological implications in its action. But as Caroline said, the better you look after yourself, maintain a healthy lifestyle and keep your weight down and stick to a good diet and stop smoking and stop drinking and stuff like that. That sort of minimizes the impact of diabetes on impacting on sexual function.
Great. So Carolyn, then is it inevitable for men with diabetes to get erectile dysfunction, or can they prevent it?
Yeah, no, it's not inevitable at all. And I think we're getting better. I think the population's more aware, and we step in sooner. We make the diagnosis, and we have effective treatments, not only the lifestyle treatments, but also medication. And so if we can get involved early, make the diagnosis, and certainly get the person involved as well in their own care, it's certainly by no means a fait accompli that they will develop erectile dysfunction. When we think about what can go wrong with diabetes, diabetes, I stand back and I usually say, and we're talking about men in this instance, that we worry about the effects on small blood vessels, and that's why people associate eye disease and kidney disease and, pleasingly very rarely now, but problems with legs and limbs and amputations with diabetes. But for most men, the relevance of their diabetes is that it is another risk factor for cardiovascular disease. And that's the biggest health challenge that a man faces anyway. That and cancer, the diagnosis they're most likely to see in their lifetime. And so just like having high blood pressure, high cholesterol, and smoking is a risk factor for heart disease, so indeed is diabetes. And the link between heart disease and erectile dysfunction for men is that when you talk to people about risk factors for heart disease, pretty much everybody knows the ones I've just talked about. But when you say to men they are exactly the same risk factors as applied to erectile dysfunction, they're often surprised, because it really, as Michael said, it is a problem with the small blood vessels. It's a plumbing problem, if you like. And the importance of thinking about erectile dysfunction, so a man might come along and be concerned about his erectile dysfunction, and part of me is taking that on board, and part of me is thinking I need to be thinking about this gentleman's heart as well, because there's some great studies that show us that you're more likely to present 3 to 5 years earlier with your erectile dysfunction than you with your heart disease. So it's a bit like the canary in the coal mine, if you like. So not only does it provide an opportunity to give care in that way, it's an opportunity to talk about heart disease as well.
So Dell, I know you do a lot of education for health professionals, etc., about diabetes and the symptoms and side effects. Do you tend to find that they are comfortable in talking about these things, or is it something that sometimes you get met with a bit of people saying, "Oh, I don't know how to bring it up with my patient"? Or...
Simon, I think what it is with diabetes, nurses also have an opportunity, a window of opportunity, when they do maybe part of the diabetes annual cycle, to quite constructively have or start a conversation with men about their sexual health, because it really is part of diabetes management. So what I teach other health professionals to be is to take that on board as part of that management. And so those probably more sensitive discussions or conversations become much more comfortable for both the health professional and the nurse. So in my own practice, there has been many times when I have gone through an annual cycle and I've said, as part of complications explained about erectile dysfunction, and just ask that question, you were experiencing any of those sorts of problems? The number of times that men will talk to me about that. And it gives me then the opportunity to talk to them briefly about it, but then also say to them, look, we probably need to book you in and you can have more of a chat with your GP. So nurses have a wonderful opportunity of gaining that window of opportunity where we can refer on. So it's an important role that we can do. And usually men, can tell nurses quite a few things, really.
Yep. And for those of you who have just joined us, we're here with Associate Professor Carolyn Allan, Nurse Dell Lovett, and Dr. Michael Lowy, talking about how diabetes can affect your sex life. We're answering audience questions. I've got one actually just waiting at the moment. So if you'd like to ask one of the experts a question, be sure to do so. If you're on Zoom, ask the question via the Q&A button. And if you're on YouTube or Facebook Live, ask the question by leaving a comment. Now, we've had a question come in, and I'm going to let any one of you answer this one. So first in, should have given you buzzers. What sort of diet is the best to prevent type 2 diabetes? Is a plant-based diet better?
I might start by having a go and say there's lots of trends and lots of discussion around this. There is some very good evidence for a Mediterranean-based diet, which has been well publicised by the CSIRO. There is some good literature now around intermittent fasting, that it may have benefits over and above just reducing your calories overall, but adding the fast element in. And of course, people such as Michael Mosley have been widely publicised with their approach to diet. So plant plant-based, yes, but there is also evidence for with lean protein. So it's avoiding in the very simple things are avoiding what we call the high GI carbohydrates. So the typical sugary foods that you think about. Then there is also an element of reducing portion size, and then over and above that, there is this out there. There is in more recent times discussion around intermittent fasting.
Great answer. Thank you. And we've actually just had another question come in. So someone actually asked, and this might be off the back of what you said, Dell, is how do I start the conversation with my doctor about the possible effect of my diabetes on my sex life? I'm worried about it being really awkward and embarrassing.
That's really where people quite often stumble. And what really works well, and it's not just for diabetes management, but it's about how can patients best manage their consultation with their GP or their specialist. And what works well for a lot of people is if you just write down in dot points on a piece of paper the things that you really would like to discuss, because sometimes by the time people get in to see their GP or their specialist, a lot of what they would have liked to have asked, it's gone out of their head. So writing those dot points and having a think about what you'd really like to discuss with your doctor is really important. And health professionals really like to see that. Maybe they can't answer all the questions you have in one consultation, but probably prioritise what you'd really like answered. And some of those things are what the GPs often want to know is, how are you feeling and how are you coping with your diabetes? What are the things what can I do to improve my diabetes? And certainly with erectile dysfunction, there are several things that make a considerable difference, as Carolyn was saying. So it's asking those questions about how can I improve this? What am I doing here? Am I doing the right things? Also, being prepared to ask about medications and their effect, and do they have any effect on erectile dysfunction is important. And also seeking advice and counselling if that's what you need, because again, diabetes is that 24/7 disease over a long period of time, and often people do get burnt out with it, and every so often it's nice to just have someone help you kickstart again so that you can get back on track.
And so Michael, if in all the people that you've seen, I mean, I'm guessing that you've never been shocked or embarrassed by anyone's questions. What's the best approach, you reckon, for someone to talk to their GP?
I think, well, firstly, the GP could say to the patient who's got a condition like diabetes where there may be an increased incidence of erectile dysfunction, you could say, is there anything else you'd like to talk to me about? Or you could say, I've seen a few patients lately with diabetes who complain about their sex lives. Is there something you'd like to discuss with me? That's one way. But the patient could say to the GP, look, there's just some other, I've got some concerns I'd like to discuss with you. Now, not all doctors are open to this sort of discussion, but many are, and many doctors know that there are like referral.
Oh, we've lost Michael for a minute there.
Just frozen there.
Places like myself and others to set, look, it can be tricky, any discussion between patients and doctors, and whenever I talk to GPs, I always talk about the barriers between doctors and patients about talking about something very personal. So it can be opened up with a very simple question, like anything you'd like to talk to me about. But the other point I also want to make is that we look at holistic medicine in terms of a patient, an older man who's got erection problems and may well have diabetes, but we also think of other things as well. We just don't focus on that one thing. We think of, like, does he have an enlarged prostate? Is he getting up a lot at night time to go to the toilet? Does he have sleep apnea? Is he a snorer? And not all men have sleep apnea snore, but they're very tired during the day. So a man with ED, diabetes, is often it's a great opportunity to do a lot more for that patient than just treating his erection problems. And certainly the cardiovascular point of things, I would send most of my older men who come to me for sexual problems for cardiological assessment, because you've just got to make sure that they don't have an underlying, because coronary artery disease can be very silent and it might present with an erection problem, particularly if they have diabetes.
So we've had a couple of questions come in about age that are age related, and I suppose they're sort of both ends of the spectrum. I've touched on something that Carolyn said before, which was someone's asked, what age do I need to start worrying about my diabetes affecting my sex life? Is there a certain age, if you've had diabetes, that you've got to get more concerned, or is it more about management right through the course?
Yeah. I guess a couple of answers. It would be different. So for type 1 diabetes, the longer duration of diabetes and relates to the level of control that you have. So there's no one specific time, but the longer you've had your diabetes, I'm sorry, that's a bit general, but the longer you've had your diabetes, the more likely you are. And particularly for type 1 diabetes, we'd be thinking about if there were other neurological problems as well. So I started to see your problems with nerve function in the feet, or problems, what we call an autonomic problems, perhaps problems with digestion, and they had kidney problems or eye problems, then I'm starting to think they're accumulating some problems that affect the small blood vessels. I'd be very much thinking about, for men, thinking about the impact on their erectile and sexual function. Yep. For type 2 diabetes, it's a little tricky, because you might have had your type 2 diabetes for quite a long time before the diagnosis was made. So even though you mightn't have had it apparent for very long, it might have been there in the background, and then your risk of developing a sexual dysfunction really relates to not only duration but your other risk factors as well, that in terms of heart disease, high blood pressure, cholesterol, smoking, that type of thing. So it would be a bigger picture, if you like.
Yep. So with type 2 diabetes, if I have type 2 diabetes and I go away and lose weight and get fit, does that mean that my erectile dysfunction goes away?
So for a long time, there were no studies to prove that, and we wanted to say to people, if you go ahead and you do that, there's every chance. There are now some studies early on with the diabetes that say if you address those risk factors, you can reverse your diabetes, and there is some literature to suggest that you'll also improve your erectile function. So absolutely, we would encourage everybody to go off and do that, because of course there are all the other benefits as well. Plus, as Michael alluded to, testosterone levels, which are can be lower in men with type 2 diabetes. It may improve that. It may well improve sleep apnea, which has an overlap then with prostate symptoms. So all of these things are bound up together. And whilst talking to men about exercise, diet, that type of thing is not particularly easy sometimes, or it sounds particularly high tech, there are good scientific studies to show that you do better with that than you do with some medications.
Yep. And so our other age-related question is asking how much of a factor age is, specifically being over 80 on having erectile dysfunction. Michael, is that something you see in terms of how it all comes together?
Yeah, absolutely. Look, while age isn't a pathological process, it does affect the physiology of blood flow and getting an erection, holding an erection, and impacts on testosterone levels and all sorts of things. So the research shows that above 80 years of age, about 80% of men will have some sort of erection problem, maybe a little one, a moderate one, or a major one. So there's really only 20% of men over 80 who will have no complaints. So while we're dealing with men with diabetes in their 50s and 60s who are complaining of sexual problems, they're also getting older. So so you've got the added issue about their age. Getting older is not always so kind to sexual function, and that's why it's important just to be as healthy as you can be. We always go back to weight issues, exercise, don't smoke, keep your alcohol down. All that maximizes your erection blood flow, to keep yourself as healthy as possible. But inevitably, there's going to be some changes that, we just can't prevent. But we have some excellent treatments. And so there's no, there's no stopping anyone being sexually active at any age with or without treatment. And of course, the type of sexual behaviour you have is, we don't always aim for the full sexual experience in an older person, but we promote, sexual play, sexual behaviour, any form of intimacy, is seen as a good thing.
Yep. Now, I can almost see the frustration and the concern in this next question. Person's asked, so if my diabetes team or GP aren't comfortable talking to me about sexual issues, who can I talk to?
Well, I think it is about starting that conversation. I think a lot of health professionals really would like to discuss this issue more. It's just starting that conversation, that first couple of words can lead on then to, a very fruitful discussion about treatment options, etc. So I think it's encouraging all players, and certainly men. It's an important part of life, and it affects not only men, but of course their intimate partners as well. So it's one of those types of discussions that even just where you start off, it can develop into, a fruitful discussion where a treatment option can be planned. So, start that conversation.
And if I can jump in and say, I guess that emphasises the importance of having a good primary care physician, a good GP, somebody that you're comfortable with. And there wouldn't be many, diabetes is, so widely spread in our community that most GPs, even if they don't have a particular experience with sexual function and sexual health, will certainly be aware of managing diabetes. And if you're having that conversation and it's a bit like, hey, look, I'm just a little concerned, or look, I've read about, that there can be, sexual problems, and I'm worried that that's part of my diabetes, then often, that I'd be very surprised that even if that wasn't their area of expertise, that they wouldn't say, look, we have, we have a nurse practitioner, we have another GP, there are endocrinologists, urologists who have an interest in that area, I think it's a really good idea to go off and have a discussion, and because of course for most conditions now there's going to be an answer. I think the advent of the little blue pill of Viagra, Michael will attest to, really changed the way we had the conversation, because we now had a good treatment option for managing erectile dysfunction. So we as the medical profession became more comfortable about asking about it because we had actually something that we could offer. Michael, I don't know, what do you...
Yeah, look, I agree with everything you say. That even though we have such wonderful treatments for sexual erectile dysfunction, it always still important to always involve the partner, because sometimes there's a lot of disappointment. The guy with diabetes and ED, he might be very proud of this little blue tablet that he's just acquired, but it's something that he does need to discuss with his partner, because sometimes it doesn't quite suit the partner for the situation to improve. So it is usually a couple's issue, but not always, of course. And I always recommend involvement of the partner if possible.
And is it fair to say that if your GP or your health professional's level of discomfort is actually making you uncomfortable, it's probably time to look for someone else to be part of your health team? So we've had another question asking, are there different types of medication for ED? And if so, what are they? And is it all medication based?
Can I answer that?
Yeah.
Yeah. Well, the one everyone knows are the tablets, and there was a blue tablet once. Now there's 4 tablets, and they're called PD5 inhibitors. And look, they're all very effective. Each one is as effective as the other, and that generally is the main initiating treatment. If as long as the patient's well enough to engage in sexual activity and is not on any nitrate medication, that's either heart medication or recreational, what you got, amyl nitrate, recreational drugs. So that would be the prime thing. But sometimes even before we get to treatments, we actually can, with counselling, we can actually improve the patient's sexual function just by looking at like doing basic sex therapy, sex counselling, looking at the way sexual activity is carried out. You can maximise sexual activity just by enhancing the various things that the guy might do with his partner or might do on his own. But if all else, if that just doesn't work, then we certainly look at medication. And if tablets don't work, we have penile injections, Cavaject and prostaglandin stuff that were around even before the tablets came on, and they're still very effective, and they tend to be used for the more difficult cases. And then there are vacuum devices, and we've got things like shockwave, acoustic shockwave therapies coming in, and gene therapy, stem cell therapy is the future. That's all being experimented on. And finally, there's an insertion of a penile implant. That's the last treatment. It's irreversible, but it's still a very good treatment. So there's lots of different treatents to suit everybody.
Yeah, it's a fair bag of tricks. There really is no reason not to have the discussion, is there?
No, not at all. And there's always something for everybody. And if you don't decide on any treatment, at least you've had a discussion with the patient, and the patient can go and think about it, talk to his partner, or there's lots of possibilities, and there's so much online stuff. I mean, there's good stuff online, especially if you go into Healthy Male website. A lot of websites are not scientific, and there's some ones that we don't recommend, but generally there's a lot of information out there, and there's a lot of choice.
Yep. And so look, we've spoken a lot about erectile dysfunction, but are there other sexual health problems that are caused by diabetes?
If I can start there, one that we think about even more so now is actually the risk of urinary infection, or an infection around the penis called Balanitis, which is an infection around the end of the glands, the foreskin of the penis. And that can occur if a man's got very high blood glucose levels, but it's also, there is a new class of drug that's become available and very widely used now in type 2 diabetes, because it's been shown to have a very good effect on the heart and on the kidneys, and it really is becoming standard of care. And one of the side effects of that class of medication, they are called the SGLT2 inhibitors, is the risk of urinary or genital infection, both for men and for women. So that is now something that I proactively talk to my patients about if I'm starting them on that class of medication. And I think that's something that's changed in the discussion in the last few years as we use those medications. And sometimes just having that conversation when I'm talking about medication sort of sets the scene also for a wider discussion. So talk about opening up the conversation. So that's one very specific thing. Another factor is whether there is just an effect on low libido, low sex drive in itself. And diabetes per se shouldn't do that unless you are quite unwell. There are other factors. But of course, if you have some erectile dysfunction, that can have a negative effect on sex drive and libido itself. And then we get asked the question, and this has been particularly my area of research interest, has been the correlation between low testosterone levels and diabetes. And so we know that we're more likely to see men with diabetes who've got low testosterone levels, and again, usually in the setting of obesity. And the question relates to which is the egg and which is the chicken. And then sort of not so much sexual problems, but again, we've alluded it to, is lower urinary symptoms, prostate symptoms we also see more commonly. So yes, there are a number of other symptoms. Everybody tends to think about erectile dysfunction, but there are a number of other aspects of sexual health that are impacted.
Yeah.
Yep.
Can I say a man who has erectile dysfunction will actually present to you with complaining of low libido, and he may have a low testosterone, but more than likely he doesn't. But his interpretation of his difficulty getting an erection is that his libido is not strong, or it becomes secondary. He loses his libido as a secondary effect. So sometimes it needs a little bit of detailed questioning with the patient. Are we talking about your sex drive? Are we talking about the ability to get and hold an erection? Well, are we talking about your ability to ejaculate? Are you ejaculating too quickly, or as men age, they tend to slow down and start to struggle to ejaculate? Again, that may be a diabetic problem or a problem of getting older. So sometimes you need to be a little bit specific with the patient about exactly what the symptom is. But each part of each symptom, can be addressed and can be treated.
Yep. So we've had a question which is very interesting, especially last night we were talking about the future of fertility in men's health. But someone's asked if my son's type 1 diabetes can affect his fertility. And if it does, should he be storing semen as soon as possible?
As a general rule, there should be no impact of type 1 diabetes on fertility and sperm production per se. Sometimes men with long-standing type 1 diabetes and nerve damage can have something called retrograde ejaculation. So they are making sperm, but it doesn't, because of nerve damage around the neck of the bladder, the sperm is delivered backwards rather than forward. So that's a very, very specific problem, very unusual, but can be managed, and you would need assisted conception. But no, if all other factors being equal, there is no reason to think that having type 1 diabetes will impact upon sperm production.
Right. Now, sorry, Dell, you wanted to add to that?
Well, just really, I suppose that when you're looking at couples being older now and deciding to put off having a family until later, there is sometimes, the male might have type 2 diabetes to begin with, and it's the preconception health that's important in that area as well. And it can sometimes be just not given probably any prominence. So it's very important that men and women both have preconception health, particularly men who are deciding, that it's time they want to start a family.
Yeah, I think most men don't actually realise that their sperm starts getting produced 3 months prior to ejaculation, and so their health, preconception health, is very important for the healthiest possible baby they can have. And they've got there was a lovely term last night, is that they're actually responsible for the future health of their child. So they've got to get as fit and healthy and well before they start making babies. Now, I'm not sure if you're all avid Financial Review readers, but in the Financial Review this morning, there was an article by Jill Margot on a study done by Professor Gary Wittert recently. And so the research about testosterone injections being able to help diabetes. And they want to know basically, okay, so what are the risks in that?
Okay. That's probably for me, because I was a co-investigator on that study, and that has been about 10 years of our lives involved in that study, a study called the T4DM study. It's the largest ever study of testosterone treatment, and it was 900 men, and these were obese men who were at risk of or had early type 2 diabetes, and over a 2-year period they all took part in a Weight Watchers program, and half of the men got injections as well. And at the end of the study, those men who'd had testosterone as well had slightly lower glucose levels. So that's a positive finding. However, it is a much bigger picture than that. And again, we know we come back to the diet, the exercise, and those men who did better with their exercise in the study and out in other studies will do better in terms of their diabetes risk. And the question remains with testosterone therapy about long-term risks, in particular cardiovascular risk, relevant to our discussion today. And whilst it remains a very controversial area and we don't have definitive evidence, we are concerned about prostate health. It's probably not particularly likely that you are going to create a prostate cancer. You need to be very certain a man doesn't have one. But yes, we are aware that our study will provoke further discussion. Where it fits in the armament of men's health, I think time will tell, but it certainly isn't going to be the panacea, and isn't a case of, hey, I'll either have an injection or I'll go to the gym. It's not, unfortunately, quite that simple.
Yep. So look, our last question before we wrap up. someone's written in and said, look, they've tried Viagra and other tablets, but nothing's helped. So what do they do next? Michael, I reckon that's you.
You know, when a patient says it doesn't work, it's not always the case that it doesn't work. It may not work according to the patient's expectations. Most treatments do work somewhat, but maybe not as good as what the patient was used to or expects. So much of the outcome of these drugs is expectation. It's going to be harder to make a perfect erection in an older man, but I go for a good enough erection. Like I want to make it functional, but not necessarily like it was when you were younger. But sometimes Viagra doesn't work. One, because it's taken. There's not enough time between taking it and engaging in sexual activity, or the person may have consumed a very large meal or drunk a fair amount of alcohol, which all impacts on it being digested and being ready for action. So there may be just logistic factors about how you take it and stuff like that. And so we sometimes find that taking a medication, not at full dose but a little dose every day, is more effective in terms of being ready for sexual activity than actually one loading dose. But every person is different, and every situation is looked at individually. So I never take it doesn't work totally as a fact, but I really investigate, find out, and then I offer a choice of the other PDE5 inhibitors. Remember, there's 4 on the market. And then, if it seriously doesn't work, and the blood flow may just be so bad into the penis that none of these tablets will work. So then we consider penile injections, and we go on sexual technique and bring the partner in and talk about maximising their sexual behaviour together.
So are there side effects to these PDE5 inhibitors, the Viagra, Cialis, these things, Michael?
Yeah, there are. These drugs promote dilation of blood vessels in the penis, which makes the penis brings blood in, but sometimes a little bit of that dilation goes to the head. So you might have a bit of a flushed face, a headache, a bit of blocked nose. These are the classic PDE5 inhibitor side effects of blood rushing to the face, and occasionally it gives a bit of reflux too. You might complain of a bit of indigestion, a bit of acid reflux. And particularly with tadalafil, there may actually be sometimes back pain or leg pain. No side effects are dangerous, but they may be uncomfortable. There may be a reason for not taking the medication or for changing to another type. Everyone reacts differently to all the different types of the 4 on the market.
Yep, great. So I suppose in wrapping up, one of the key things is have a relationship with your health team, have a health team. And make sure you're open to having a chat to them and talking to them. And if you don't think they're open to that conversation, we'll find a health team that does. So thank you all for viewing this tonight. And that's a wrap on our second live event for this Men's Health Week. It's been great that we could have so many people join us live for the Diabetes and Sexual Function, Mental Health and Relationships webinar. Thank you to Carolyn, Michael and Dell for joining us and for their learned insight. Please visit www.healthymale.org.au to learn more about male reproductive health, and join us tomorrow from 12 noon to 6 p.m. Eastern Standard Time on Reddit. So if you haven't got a Reddit account, go and get one, to ask all and any questions you have regarding male fertility. If you've ever wondered it, now's your chance. We've got a panel of experts waiting to answer your questions. You've got 6 hours, so you've plenty of time to ask the questions. They're waiting to get responses back to you. You can also follow us on Facebook and Twitter. We release new information weekly in articles, videos, Q&As and more. Thank you, everybody, and thank you to our panel, and bye for now and stay safe. Thanks.